Hello, everyone. Welcome to NY Cannabis Grand Rounds, brought to you by New York State Office of Cannabis Management. My name is Sang Choi, and I will be a moderator for today's webinar. And we are delighted to have you with us today, whether you are joining us live or watching the replay. And today we are happy to welcome Dr. Ben Caplan, who is a board-certified family medicine physician and a leading voice in clinical cannabis medicine. He has over 20 years of patient care and research experience, and as the co-founder and chief medical officer of CED Clinic, the Commonwealth Project, and EO Care, where he has provided care for more than 25,000 patients and shaped cannabis guidance internationally. Dr. Caplan is the author of the Doctor-Approved Cannabis Handbook, a comprehensive guide for both clinicians and patients, and he has pioneered cannabis technology initiatives. And notably, he was the first clinician to teach medical cannabis at Harvard Business School and continues to influence national cannabis policy through his leadership in the DEA's rescheduling hearings. For today's presentation, Dr. Caplan will be sharing an evidence-based roadmap for integrating medical cannabis into the Medicare, which we all know is the healthcare system that seniors rely on most. We hope that the discussion will shed light on recent research findings, practical integration strategies, and opportunities for providers, patients, and policymakers to advance access and quality of care. But before we begin, I have to read an important disclaimer. The Office of Cannabis Management makes no claims, promises, or guarantees about the accuracy, completeness, or adequacy of the content of this video live stream event, and expressly disclaims any and all liability of the content and for errors or omissions in the content of this live stream video event. This video live stream event is for informational purposes and convenience of the public only and does not constitute endorsement, recommendation, professional advice, or favoring by the Office of Cannabis Management. The content of this video live stream event is based on information available at the time of recording and is subject to change. So without further ado, please take it away, Dr. Caplan. And for the audience tuning in, I encourage you to note any questions in the chat for our Q&A segment following the talk.
Sounds great. Thank you, Sang. And thanks everyone for making time to be here. I want to start with a picture, not a product, not a plant, a road. Now, picture that road as our healthcare system. If you're dealing with diabetes, high blood pressure, a broken hip, Medicare helps pave the way. It's not perfect, but it's a path. But if you're a senior looking for cannabis care, suddenly that road crumbles. No coverage, no signs, no support. Patients are left to navigate it totally alone, out of pocket, in the dark, or just left behind. This talk isn't about cannabis products or the marketplace. It's about fixing the care system around it. I work with older adults every day, smart, thoughtful people who are finding relief through cannabis, but being failed by the systems meant to support them. Over the next 30 minutes or so, I'll share a look at the data. We'll hear patient stories, and we'll lay out a roadmap because there is a way forward. So let's get into why this matters and what we can actually do about it. Every sign on this road tells a real story. We'll begin with two of my patients, Margaret and Robert, seniors navigating pain, sleep issues, and silence from the system. Then we hit the paradox. Medicare covers sedatives and opioids, but not cannabis, even when cannabis works better, even when it's safer. We'll look at what's not being said, the gap between what patients need and what providers are allowed to recommend. Then the bigger picture, how outdated policies are locking older adults into care that's decades behind the science. But this isn't just critique. We'll explore where change is already happening, pilot programs, smart policies, and data-driven care models. And finally, we'll land where it counts, the practical, right now steps that patients, providers, and policymakers can take to stop leaving seniors behind. Follow the signs, follow the stories. Every one of them points to a better way forward. This is Margaret. She's 78, lives alone on a fixed, narrow income, and has severe arthritis. She did everything Medicare told her to do. First Tylenol, then NSAIDs, a bunch of fruitless referrals, then opioids. The opioids dulled the pain, but brought their own price. Stomach ulcers, constant constipation, and a higher risk of falling. Then one day, a neighbor offered her something different, a low-dose cannabis tincture. Suddenly, Margaret could do something she hadn't done in years: walk her dog, sleep through the night. And here's the twist. Medicare covered every step of her decline. The opioids, free. The cannabis that actually helps, $200 a month out of pocket. Every month, Margaret is forced to choose between food and relief. As if the system is saying your opioids are free, but your mobility, your sanity, your freedom, that will cost you. Margaret's not a one-off. Millions of people follow the same path. They start with Tylenol, move to NSAIDs, graduate to opioids, and only when nothing else works, they find cannabis. Not because it's trendy, not because they're trying to rebel at 78, because it works. But here's the catch. Every one of them ends up flying solo. No coverage, no clear instructions, no guardrails to help them avoid mislabeled gummies, dizzying side effects, or drug interactions that spike their blood pressure and leave them wobbling. So what happens? They stop asking their doctors, they stop trusting the system, and they start Googling their way through medicine. That's not progress. That's a system quietly saying, if it's cannabis, you're on your own. Last year, Medicare spent $4.1 billion on opioids for seniors. On cannabis, zero. Not a penny for the product, not a dime for education, dosing, or guidance on safe use. The message is loud and clear. We'll pay for harm, but not for healing. And that shapes everything. What doctors recommend, what pharmacies stock, and what patients believe counts as real medicine. Let's talk about sleep. When seniors don't sleep well, everything suffers. Pain gets worse, moods spiral, memory slips, and the real danger, falls. For adults over 65, falls are the leading cause of injury-related death, and they cost Medicare more than $50 billion a year. Now meet Robert. Over the years, Medicare covered every sedative in the book: zolpidem, trazodone, even benzos. The result? He slept a little and staggered a lot. Groggy mornings, wobbly balance, higher fall risk, not lower. Cannabis, on the other hand, helped him sleep through the night, wake up clear-headed, and walk safely to the bathroom. But because that doesn't count as approved sleep, it's not covered. We'll pay for sedation, we ignore balance, and seniors like Robert pay the real price for our system's blind spots. Robert's story didn't change because of a doctor. It changed because of his granddaughter. She gently suggested a tiny dose of high CBD tincture before bed, something that had helped her. And it worked. He didn't just sleep, he woke up different, clear, balanced, more like himself. And the irony, the sedatives that made him foggy and unsteady, fully reimbursed. the plant that restored his balance paid for out of pocket? In what other part of medicine do we cover the thing that causes the harm and block the thing that fixes it? Margaret and Robert aren't outliers. They're part of something bigger. Adults over 65 are now the fastest growing group of cannabis users, using it for pain, sleep, anxiety, appetite, and to cut down on pills. And here's the problem. They're doing it without a map. Most doctors, more than 90%, have had zero formal training in cannabis medicine. So seniors are left guessing or asking the dispensary clerks what they think grandma and grandpa should have for medicine. Guessing how it'll interact with their other medicines, guessing if the label on the product is even accurate, guessing alone with no coordinated care. We've legalized the access, but we've left the conversation off limits. And in medicine, silence isn't neutral. Silence is a risk factor. So if doctors don't learn about cannabis in school, you might expect the system to fill in the gaps, but it doesn't. There's no billing code for cannabis consultations, no institutional push to pursue cannabis training, and no Medicare reimbursement to support these conversations at all. And here's the kicker. Less than 7% of primary care doctors say they feel prepared to counsel patients on cannabis. So instead of safe, structured guidance, we get silence. Not because doctors don't care, but because the system leaves them unequipped, unsupported, and unreimbursed. In medicine, what doesn't get taught doesn't get talked about. And what doesn't get billed disappears. The reality today is this. This is Cannabis 2025. A senior walks into a dispensary, gets handed a brown paper bag, no instructions, no safety net, just hope and maybe a handwritten label or a high five. And this isn't fringe. Over 3 million older adults are using cannabis monthly, not to get high, to get through the night. Meanwhile, the healthcare system acts like it's not happening, quietly sidelining it like a missing chapter in the manual of modern medicine. What we've created is a nationwide DIY care model. No structure, no oversight, no one's officially responsible. It's the most common workaround in medicine today. And pretending it's not there doesn't make it any safer. Unguided care creates a blind spot in medicine. And here's how it happens. No coverage means there's no billing. No billing means there's no documentation. No documentation means there's no data. And no data, no progress. This is the quiet cycle that keeps the system stuck. Policymakers say, show us the outcomes, but you can't measure what you've never captured. Meanwhile, real people, millions of older adults, are using cannabis every day, safely, strategically, often with success. But because it's not covered, it's not recorded. And because it's not recorded, it might as well not exist. We can't fix what the system refuses to see. The irony. Let's get back to these facts. Medicare spends over $4 billion a year on opioids. It spends nothing on cannabis, even when it helps patients taper, stay steady, and feel better. And honestly, it's no wonder people are starting to ask, are doctors just paid to push certain drugs? Because from the patient's side, it feels that way. Especially when the only thing that's worked for their pain, their sleep, their anxiety, is the one thing the doctor avoids. Add to that a system where doctors barely have time to know their patients anymore, and it's trust starting to crack. If patients know cannabis is helping and their doctor doesn't, or worse, won't even ask, then what's left of that relationship? We didn't just sideline a medicine. We sidelined this connection. And for a growing number of people, the medical system no longer feels like it's on their side. This isn't about bad doctors. Most clinicians I know generally want to help their patients use cannabis safely. But here's the reality. If they speak up, there's no billing code. If they recommend cannabis, there's no clinical template. If they spend time on it, they're doing it off the clock. So what happens? They stay quiet, not because they don't care, but because the system makes curiosity feel like liability. That's the heartbreak. When doctors do nothing, it's not always from apathy. Sometimes it's because they've been trained not to touch what isn't reimbursed. And when doing the right thing comes with risk, even the best clinicians default to silence. And silence isn't a gap in guidance. It's a barrier to safety. Rescheduling to Schedule 3 sounds like progress. And if we were just chasing headlines, it might be. But for real patients and real providers, it's mostly symbolic. What does Schedule 3 actually mean? It means coverage, but only for FDA-approved products. So Epidiolex, maybe. A high CBD tincture from your local dispensary, still out of pocket. Capsules, topicals, edibles, the things seniors actually use, still uncovered, still uncharted, still good luck out there. Rescheduling changes the label, but not the access, not the reimbursement, and definitely not the care. If we want real progress, we need to move more than just a new schedule number. We need a new framework. CPT codes so doctors can stop flying blind. CMS pilot programs that test, not just talk. Clear safety standards so providers aren't guessing at every gummy. Because right now, rescheduling is like putting fresh paint on a locked door. It looks nice, but it still doesn't open. A smarter path. We don't need Congress to fix everything overnight. We need permission to try smarter things. And that's what CMMI waivers are built for. They let us pilot real-world programs, the kind that pay clinicians to guide patients through cannabis care safely. Here's how it could work. A provider talks with a patient about cannabis. They bill for that time just like any other counseling visit. Outcomes are tracked, pain scores, sleep, med reduction, side effects. No guesswork, no one off the books, just structured, billable, data-driven care. And with that data, we learn what works, what's safe, what's scalable. Think of it like a bridge. You're building a bridge, you build it plank by plank, not with promises, with proof. From pilot launch to policy change, this is how we move forward. Not all at once, but one smart step at a time. Imagine a future where cannabis care isn't hidden in paper bags, where it's not whispered about in waiting rooms or tiptoed around in chart notes. It's structured, it's safe, built into care plans, reviewed at follow-up, just like diabetes, just like heart disease. Doctors are trained, patients are guided, and outcomes are tracked, not guessed. No stigma, no silence, just medicine that works, delivered with clarity and care. That's not just progress, that's dignity. And that's 100% what I want for my own patients. You don't need new laws or new credentials to make a difference. there are 3 things every provider can do right now. Number 1, ask, have you tried any cannabis or CBD products? A simple question that opens the door to safety. Number 2, document. Add it to the med list, just like any other therapy. It matters. It interacts. It belongs in the chart. Number 3, refer. If you don't have all the answers, point your patient to someone who does. A trusted clinician, a vetted resource, that's still care. These steps might seem small, but they close the silence gap. This is where we're headed. A system that doesn't sidestep cannabis, it supports it. Providers ask about use, they guide care, and feel confident doing it. Systems document cannabis like any other therapy because they recognize it as real medicine. And Medicare, it backs the whole thing. With pilot programs, with coverage for clinical time, with a commitment to data, safety, and outcomes. This isn't fantasy. We have the tools. We just need to use them together. Documentation isn't just a safety practice. It's a signal of what medicine is willing to recognize. And recognizing cannabis, charting it, studying it, guiding its use, is how we start integrating it into the medical ecosystem where it belongs. Cannabis doesn't work like most drugs. It doesn't target just one organ. It's more like exercise or nutrition, affecting mood, sleep, inflammation, pain, immune response, all at once. But unlike broad tools, it also works locally, balancing imbalances in specific tissues, adjusting tone within individual systems. So where does that fit in a medical model that treats people like machines, one broken part at a time? It fits into the mortar, the connective tissue of care. And until we make space for that kind of tool on the chart, in the data, and in the conversation, we're not treating the whole person. Documentation is where the paradigm shift begins, from fragmented care to truly integrated health. We can't wish our way into better cannabis care. We have to build it. And that starts with 3 things. First, Medicare needs pilot programs to test coverage under real-world supervised conditions. Second, we need data tracking because what we don't measure, we can't defend or improve. And third, we need education for providers, yes, but also for policymakers and the public, because stigma doesn't disappear just because the science is good. Pilot programs, data, training. That's how we pave the way to smarter care. Basically, test it, track it, teach it. If CMS can do that for insulin pumps and joint replacements, it can do it for cannabis too. While we fight to fix the system, there are steps we can take right now, especially for older adults. First, match the method to the person. If someone has arthritis, don't give them a tiny tincture dropper. They'll hate you. Go with sprays, soft gels, and dissolvables. Second, match the product to the purpose. High CBD blends help with daytime calm, focus, and inflammation. Balanced ratios are best for mood, sleep, and overall relief. And THC dominant formulas, when you time them precisely, can boost appetite, ease pain, and improve your mood. Third, individualize the dose. About 1 in 4 seniors metabolize cannabinoids very differently. Some need 1/10 of the standard dose. Some need 10 times more. Personalized care matters. Cannabinoid metabolism isn't one size fits all. Some bodies break it down 10 times faster or slower than others. And last, but maybe the most important, normalize the conversation. When cannabis use is openly discussed, mistakes get caught early, stigma fades, and families feel safer. Sidebar, if you're looking for a practical reference you can hold in your hands, one with real routines, real patient examples, and actual science behind every claim, I put together the doctor-approved cannabis handbook just for that reason. I spent 10 years collecting what works, and more importantly, what doesn't, for adults using cannabis. It's not a memoir, it's not fluff, it's just evidence-based, easy-to-follow guidance for people who actually still read books. There's a QR code here if you want a copy, or don't, I'll never know. The point here is that we don't need a perfect system to start practicing better care. We just need a generation of patients who aren't afraid to speak up and a few clinicians willing to listen. You know, the biggest barriers to cannabis care for older adults, they're not political, they're personal. They show up in the smallest, most frustrating places every single day. Hands that can't open child-proof caps. Fonts so tiny, you need a microscope to read them. And even then, good luck figuring out what the instructions actually mean. Confusing names, unclear dosages, no standard format. And maybe hardest of all, silence. The fear of being judged, the fear of being wrong, the fear of even bringing it up to your doctor or your family. From the outside, these things might look like not that much. But if you're the one facing them day after day, they're not just little hurdles, they're brick walls. And we can't talk about access to care without talking about how to knock down these walls. And if you've ever watched a 7 or 8-year-old wrestle a child-proof jar with a butter knife and a magnifying glass, you know this isn't just a theoretical issue. Over 70% of older adults using cannabis are doing it without any professional guidance. Not because they don't want help, because the help just isn't there. But the solutions, they are not complicated. We need tools that make sense, packaging seniors can actually open, doses they can trust and repeat, labels that speak plain English, and spaces where questions are welcome, not judged. When we apply the same safety standards we already expect for any medication, cannabis stops feeling like a gamble and starts feeling like real care. No one's asking for a rocket launch, just something safer than a guessing game with THC. This isn't just a story arc, it's a pressure map. What starts with a few patient stories turns into a pattern. Pain that isn't managed, sleep that never comes, stigma that keeps people silent. Policies built for someone else's body. When enough people hit the same wall, it's not a personal failure, it's a system failure. And it's already affecting 71 million adults, with millions more on the way. Whether the system keeps up or not, the shift has already started. And if anyone's still wondering whether seniors are ready for cannabis, just remember they survived disco, dial-up internet, and 3-button remotes. Cannabis care isn't some fringe workaround. It's care, and it belongs in the system. The science has arrived, the patients are here, the need couldn't be louder. At this point, it's not a debate, it's a delay. And the real question isn't if coverage will happen, it's how long the system is willing to make people suffer while pretending it hasn't already started. The sad fact is that Medicare moving at the speed of dial-up modem here in a world that's already gone fiber optic. While we dive into questions, I want to share a quick reminder. If you're looking for free doctor-approved education, you have options. My team and I respond fast for anyone that wants one-on-one connection. And for anyone who prefers video or social media education, I try to teach online as much as I can. And for everyone tuning in today, if you shoot a quick email to free@cedclinic.com, that's cedclinic.com, you'll get a 3-month free subscription to my newsletter, one of the top 50 Substacks on the platform, but it's packed with science, routines, real world guidance, and just enough sarcasm to keep it interesting. And with that, we have time for some questions.
Dr. Caplan, thank you so much for your presentation and for all the information that you've provided us. You know, I just found one of your slides, you said, are seniors ready for cannabis? And I think they absolutely are. I think, you know, I was a dispensary pharmacist for a long time in New York State, where pharmacists are mandated to be in dispensaries. So the percentage of, you know, older patients that I saw, it was a significant number. But, you know, you take into consideration the complications of like certain disease states and, you know, symptom management and polypharmacy where they're on multiple drugs. I think it is important to have that guidance. So thank you for working towards, you know, seniors and insurance coverage. So let's take some questions. Okay. So are doctors taught about the endocannabinoid system?
Not at all. I mean, even if they are, it's not real clinical medicine. The stuff we read about in textbooks is not the same as when someone comes in. What do we do with that? How do we help someone who also has complexity? You know, the shocking reality, maybe to many people listening, is the endocannabinoid system wasn't discovered until the 90s. It's not in medical textbooks. It's not taught still today, but there's no passing on of knowledge and experience. It's a completely crumbled system. Mm-hmm. There are crazy doctors who dive into this stuff, and there are many of us. But we're lone soldiers, and we have a hard time kind of pushing the message out. You know, people judge us like we're on some cannabis company payroll, not actually trying to help. So it's an interesting problem, and this has never happened in medical history. And unfortunately, it happens to be a system which is the most widespread communication system in the body. Yeah. It's a big deal. It's probably one of the most consequential systems in the body. And here we are, empty-handed.
Yeah, I mean, I agree with you. I mean, it goes back tens of thousands of years, the first documented use of cannabis. And knowing that every mammal with a backbone possesses the system that we don't optimize. So yeah, I agree with you. All right. Why is medical cannabis that a patient has a script to receive not allowed in any rehab or assisted living facilities?
Yeah. So there's a lot of gray area these days. The 2018 Farm Bill made CBD fully legal. You can ship it, you can mail it, you can bring it on a plane, you can use it anywhere. But THC, fully illegal. You know, and for people, if you could look under a microscope, you'd see the differences between these molecules is almost negligible. Right. And in some circumstances, like acid in your stomach, they actually interconvert. It's really silly. But nonetheless, it is what it is. THC is fully illegal. Most of the scripts people get are for THC. And most clinics and hospitals and hospital settings are kind of federally funded, or they're federal facilities, or they have nurses that have federal union contracts. And it's not allowed. It's a ridiculous predicament, as this whole talk probably pointed out. But it is the ridiculous system we have, and what needs to change.
Yeah, and I just like to note that in New York State, as a part of our expansion of the MRTA, you know, senior living facilities and rehab centers are able to designate themselves as caregiver facilities. So as long as they have their own sort of, you know, rules and regulations and how they want to handle that, they are able to administer and, you know, facilitate, you know, using cannabis in those senior living facilities.
So then the nuance they're saying is important. In the structure of most of the state laws, and I think New York is no exception, there are some people who can't administer their own medicine. So they need someone like a caregiver to be able to administer it to them.
Right.
So what that means is they have the opportunity to have help obtaining cannabis, but the use of the cannabis still has to be in their private circumstances. They have no guidance with how to use it. It's not like they can consume at the dinner table or at the lunch line. It's still very private. It's just the access that caregiver has to be able to give that person the medicine. So it's an important nuance. It's not like senior facilities are amenable to cannabis therapies. They're not using it as a regular therapy. It's not like a safe spot. It's still it's still sketchy to use it. It's still hush hush. You can't do it in front of people. You can't have it in public outside of your door. It's still kind of riddled with shame.
Yeah. All right. Is it safe for someone who is currently with hospice to use medical cannabis?
I would flip this, and I would say actually it's almost unethical for people not to consider cannabis. I spent a whole chapter and a half, 2 chapters of my book talking about end of life and hospice care. And it's so important. We have this sort of fascination in our culture with getting as old as we can. We want to save every last scrap, and we forget that there's a person there who's living that life. And it's often, with needles and medicines, and they're like people poking them in the hospital. It's not a comfortable end of life. And I think we all deserve a comfortable death.
Yeah.
As sad as that can be, isn't that the best thing we can give to someone is a joyful end? And yet that's not really part of the conversation. And hospice sort of gets toward there, but the medicines that we use in hospice, like opioids and benzos, make someone snowed. They're not really enjoying their life if they're barely conscious, if they can't communicate, if they can't hug at the end of their life. And those are possible with cannabis. For those who don't know, THC happens to tickle the same receptor, the mu opiate receptors that opioid medicines do. That's part of what makes cannabis feel pleasurable. Is it tickles them. It doesn't grab onto them and sort of wrangle them the same way opiates do. People don't get addicted to cannabis the way that opiates cause addiction. But it gives enough calm, satisfaction, contentment, pleasure that someone can communicate, they can love at the end of their life.
Yeah. So which product formulations, tinctures, flower edibles, do senior adults seem to be most comfortable with? And also any challenges specific to these formats for senior consumers?
Yeah, we covered that a little bit in the talk. And I can sort of share what I've seen is sort of most common. It's not that different from everybody else, except older adults seem more comfortable with tinctures, and that's probably a good thing. I mean, it's a sort of a weird thing to put oil into your mouth. You have to look in the mirror, and it's messy, and it's hard to get the drop exactly right. But for people like older adults that want to kind of fine tune their dose, they want to figure out where their swim lane is for the cannabis. It's really great to have dose by dose, drop by drop experience so that you can judge what's best for you. As I covered in the talk, individualizing this care is so important that one size isn't going to fit all. I think the answer to sort of which products people tend to gravitate towards also depends on, what region of senior care we're talking about. Sort of younger, more hip, more able-bodied seniors tend to do what adults do, which is, mostly inhaling and gummies. I generally don't recommend people smoke anything. I'm not going to tell seniors to smoke their broccoli or their spinach. I wouldn't tell them to smoke their cannabis. There's a time and a place for it. And many seniors grew up in the sort of hippie era, and, smoking a joint sends them back to a time where they felt youthful and joyful. So that's useful. But in terms of the downsides of smoke, of course, I'm not going to recommend that. There are plenty of other ways that people can consume cannabis without smoking and without creating combustion products. But nonetheless, seniors who are younger, sort of grew up in the 60s, 70s, do love their smoke. And edibles are also popular for them. For seniors, as they get older, it tends to be more, as I said, dosed or easy to consume. One of the things I've started to do in my clinic is actually share a free recipe cookbook. And it's now possible to make mac and cheese, to make your hot cocoa, to make morsels of a chocolate cookie, each medicated. You don't have to have gummy sugar things from a dispensary. You can actually just medicate your salad dressing or have your normal life include cannabis with it. I think that's really where cannabis is going. This isn't going to be sort of a weird pseudo medicine thing. It's just going to be part of nutrition. I mean, at its most fundamental, cannabis is a vegetable buffet. It has a microcosm of what vegetation is found on Earth. It just so happens that this one freak plant happens to produce most of it.
Yeah. Okay, and I think this is our last question. So how can I help clients through therapy and cannabis use?
I mean, we sort of covered this. I think, ask, document, and refer was the sort of tagline I tried to share. I think we can't be afraid of it. Even if someone in a position of support doesn't know anything, they know how to ask questions. They know how to learn. And when you learn from the first person, you have more support for the next person. And you learn some, and hopefully that triggers some interest and you can read something. And that's the process of old school learning. I mean, before we had institutions, before we had book learning, people learned by apprenticeship. They learned by doing. I can tell those in the audience who feel sort of ashamed about it, like there's no shame here. It's really like a vegetable. The same things we worry about leafy greens with. Warfarin, people have to take an INR because we're worried about the liver effects. The same thing is true of grapefruit as it is cannabis. We're going to test those patients anyway. There's no extra worry about cannabis. They should just have their regular INRs. It's not anything kind of weird and unusual. It's just part of regular care. We just have to get rid of the stigma, get rid of the idea that this is harmful, and just be curious about learning.
Yeah, I mean, I think this also is a testament to, guidance. Having guidance would help tremendously, because then a patient would know, or a person would know what the starting dose is, and how do I start using something, or where do I start? So I think the guidance part that you talk about is very, very important. So I think we have actually one more.
I want to build on that saying, because it reminds me of something I've sort of been using lately. One of the things I think people find is broken about medicine is this lack of relationship that they used to have. And doctors used to know patients. They used to know how to talk to them, and used to know about their family and what they did. That sort of shamanism, that stuff around the pills, is missing. We all need that as humans. I think cannabis therapy, cannabis care, cannabis medicine is more like psychiatry than surgery. In psychiatry, there aren't magic words that make someone feel better, think better, or act better. And just like with cannabis, there aren't magic products actually some of them, sometimes there are, people get lucky, but that's rare. And that changes over time as we all change naturally anyway. But I think people need to understand that good cannabis care is a relationship, not a transaction. And we have this paradigm in medicine that, your hand is broken, you need hand medicine, or this sort of machine style medicine I referred to. Cannabis, again, doesn't fit that model. We need to understand it's a relationship, it's a connection. And that relationship, the relationship we have with our mother as she kisses us and we feel good, that's the endocannabinoid system. As people exercise and they feel that rush of exercise, that's the endocannabinoid system. That's not adrenaline or whatever we thought as a culture before. Cannabis is part of our everyday lives. The people, those crazy people that do cold dips, that's the endocannabinoid system. The people doing the sauna, that's the endocannabinoid system. There's so much of this that's all around us. We just didn't realize that was this system.
Right. But we're beginning to know. Okay. Last question. What are some organizing efforts we might participate in to change the exclusion of cannabis on the federal, state, and city level?
My old answer to this question would have been like, call your rep. And I don't know many people that actually do that. But I'll say the world is very different now than when I used to think about that. I think social media is our kind of collective microphone. And in this moment in history, at least, people who have nothing but a computer and a screen can have a voice that's international. So I would encourage people to ask questions online, to follow people who have interesting, useful things to say. I guess maybe not follow the people who are negative and sort of cruel and just let them die in silence. but to really enhance education, to enhance discussion, enhance curiosity online. And there's tons of places now where you can follow people, you can learn online. So I think the internet is a real powerful tool now that we've never had before. So that's probably my answer.
Yeah. All right. Well, thank you. So as we wrap up, I would like to thank Dr. Caplan for sharing his expertise and thank the audience for joining and for your participation. And we'd like to remind you that the replay of today's session will be available on our YouTube channel immediately following the presentation. You can find links to Dr. Caplan's work and other resources. We'll be putting those in the chat. And we encourage you to sign up for our newsletter to stay connected about the latest updates on events. Your feedback is so important to us. So please take a moment to fill out the post-webinar survey. And if you or anyone you know are interested in being one of our featured guests for the series, please complete the link to the form in the chat as well. And before we close, we wanted to share that the second annual New York State Medical Cannabis Symposium, Cannabinoids and Clinical Practice is happening on November 6th and 7th in Uniondale, Long Island. And we really have a great lineup of speakers, and it's a great chance to learn about the latest in cannabinoid science and clinical practice. So please visit cannabis.ny.gov /symposium for full details and registration. And please stay tuned for the next NY Cannabis Grand Rounds webinar. And thank you once again for being part of this important dialogue today. Special thanks to Dr. Caplan and to all of you for your ongoing engagement. So take care, and we look forward to welcoming you again next time.